Good afternoon, network, and welcome to this echo session. Today we'll be looking at a presentation from our M2M. I'm sure you will know more when the presenter comes on. So I just wanted to do a sound check and just to ensure that our panel of experts is available. So I want to welcome you all warmly and thank you for joining us. Our time is 2:30 and we are good to go. We are ready to start. So I can see we have about 71 connections and we're expecting more people to join. I know that Zambezi is with us, Zambezi District Hospital. Just kindly confirm that you're still with us, Zambezi District.
Hello.
Hello. Good afternoon.
Good afternoon.
Thank you, Zambezi District is a different voice. Yes. Thank you. I can also see, Lusaka College of Nursing and Midwifery. Are you able to confirm your presence? Lusaka College of Nursing and Midwifery. I can see quite a number of participants. I'm pleased to see Dr. Esther Kayemba with us. Dr. Francis Mwape is joining us from PHO. You can see Helen Nyangu, Dr. Christopher Mzungaire. Thank you for joining. Simuyemba Elvis, thank you for joining. I just want to confirm the presence of our panel of experts. Dr. Priscilla Banda, are you on the call with us? Mishek Walia, are you on the call with us? What about Dr. Priscilla Mlenga? Gwen Yondela?
I'm here.
Thank you for joining us. Good afternoon.
Good afternoon, thank you.
Dr. Chimika Piri?
I'm around. Good afternoon.
Good afternoon, sir. Thank you. Okay, I'm sure the other experts will join us in due course. So thank you for joining us once again for this session. My name is Malilwe Muhuma. A lot of people confuse my name. It's not even difficult. Muhuma has 6 letters. It's not Muhua, it's not Muhumu, it's Muhuma. Okay, now that we have that out of the way, I just want to remind you of the echo etiquette. Remember to mute your mic when you are not speaking to avoid disturbances, and as much as possible, let's keep our videos off to ensure a very stable network and communication. Last week, we were looking at diagnostic approaches in childhood TB. That was a very wonderful presentation done by Dr. David Singin and Dr. Kevin Zimba. I think at this point, we'll just probably spend a few minutes just to recap on that session. And I'll give the floor to Madam Etambuyu, who's our ECHO coordinator. She'll just go through what we did.
Thank you very much, Dr. Muhuma. So just a quick recap of last week. We learned that TB in children remains underdiagnosed with gaps in detection, diagnosis, treatment, as well as prevention. So we also learned that the use of TPT in children still remains underutilized in most of the facilities. TB diagnosis in children requires a bit more effort and a standard approach to make a diagnosis. So this cascades, the cascade effect of this pandemic is far from over, but preparation and response is key and is still underway in diagnosing childhood TB. So COVID-19 poses as a very big threat and a challenge so far, and it has contributed to all the gains that have been done so far in childhood TB diagnosis. Lastly, but not the least, healthcare systems need to adapt to the new normal. Regardless of the COVID-19 pandemic, we still have to find ways and means of diagnosing TB in children. That's the end of the recap. Over to you, Dr. Mama.
Thank you so much, Etambuyo, for the recap. Once again, today we are looking at mentor mothers supporting the full cascade of RMNCH or PMTCT services in Zambia. With me, I have Mr. Elijah Mvula, who is going to take us through the didactic presentation. But before we go into the presentation, I can see that we are at 126 connections. Please remember to register your presence. There's a link that will be shared periodically in the chat box. So you can just check the chat box and register your attendance for today. So without further ado, I will hand over to Mr. Elijah Mvula, who will then ably introduce himself and be able to take us through the presentation. Stay tuned.
Thank you very much, Chair, and good afternoon, Tim. So the Chair has already introduced me. I'm Elijah Mvula from an organization called Mothers to Mothers.
Can you share the presentation?
Can you share the presentation?
Share. So just confirm that you can see the presentation. Anybody to just quickly confirm that you can see the presentation?
Yes, it's visible.
All right, thank you.
Thank you so much, and thank you so much to the Minister of Health for giving Mothers to Mothers this opportunity to present the gains and explain a few gray areas that we need to actually clarify to do with the mentor-mother model. So we're addressing three objectives in this presentation. We'll look at the overview of the mentor-mother model, what this model is about, who are behind the model, what approaches are we using. We'll also be able to share the best practices. What is it that the model has been using and is still using to actually achieve the gains that we are going to present. And then lastly, we'll actually just outline our plans. What are we looking at? How does our scale up of this model look like? Thank you so much. Next slide. Appreciate it. So the mentor-mother model I'm going to present is a mentor-mother model implemented by a organization called Mothers to Mothers. I will call this the gold standard model because I think this is the model that achieves the results that we are going to showcase here. What is the vision of this organization called Mothers to Mothers? So Mothers to Mothers is headquartered in South Africa. That's where HQ is. And our vision is to actually achieve an HIV-free future. But then, of course, you can only achieve it if you have a healthy nation, a nation full of hope that we are going to fight and win the race to the last until we get to epidemic control. That's the vision of Mothers to Mothers. What's our mission to support our vision? We want to ensure a healthy, thriving family and an end to pediatric HIV. And that's how come whatever we're going to present, this model actually focuses on the family, apart from the other interventions that you are going to showcase. Our approach is to ensure that it's holistic. It involves every member of the family from our entry point based on what I'm going to present. Thank you, Chair. So initially, the flow of the presentation will start with our organizational achievements, and then I'll get down to Zambia, where we are, what we've done, and what milestones have we achieved as an organization, as a model. The mentor mother model, as the name depicts, actually gets from this lady that Mothers to Mothers employs, and we call them mentor mothers. So this lady is not just picked anyhow. We pick a woman who is HIV positive with certain qualifications that we look at, and this lady should be going through the PMC cascade. So meaning this lady should have a baby, actually, who is the baby which is under 24 months, which is under 2 years. That's the initial starting point of the model. Apart from just that selection, these mentor mothers go through an exhaustive, very intensive training to be able to understand the model. It's a 12 days training that we do. And this training is actually done in a very, very cascaded approach for it to actually achieve sustainability. Because remember, we are a project, but we are working with Ministry of Health. So we first train the TOTs. In country, I would like to report that we have, I think, a buffer of 15 TOTs. These are the ones that actually conduct these trainings. Whichever numbers I'll be mentioning as I get to the detail, actually, this actually comes from the training which is conducted by trained Ministry of Health staff, some medical doctors and other professionals within the Ministry of Health. After we do a TOT training, we come down to train now the actual mentor mothers. So the TOTs will increase high-level managers from provincial, district, as well as the facility level. So they're able to provide technical support, mentorship, and supervision as we deploy these mentor mothers to the ground. When this training is done, then we conduct now the training for actual mentor mothers, which is a 12 days intensive training, both class-based as well as facility-based, which focuses on adult approaches. This training, for instance, if you are looking at targeting 20 mentor mothers, we'll have maybe a class of 28 or 30 mentor mothers, because we know that after the 12 days, some of them will fall out because of what we look at. We do a pre-test, post-test, and continuous observation in the class by our facilitators. So this is a very intensive training, just to ensure that these mentor mothers are ready to deliver the model approaches to the end. So that's basically what we look at. To the left, we're trying to explain what was shown in the vision, that we are a family-centric approach. So we'll meet this lady at pregnancy, maybe in antenatal and postnatal, but our major primary entry point is antenatal. And then we'll take that lady through the process to motherhood, through the process of the child, because we need to also be taking over the HIV-exposed infant, and then into adolescence. So we are focusing, most of the numbers you are seeing are focusing on an HIV positive woman that we meet, and then the mentor mother tries to take them through this process through counseling until the lady and the mother graduates at 24 months. So most of the data you'll be seeing will be for an HIV positive, but we also focus on what I would call high risk populations, high risk women. We also focus on them. So we're not only going to talk about an HIV positive woman. Next slide, Chair. Thank you so much. So this is at organization level what we've achieved so far, focusing on the treatment effects, but also other high impact interventions that we do. So you see that since 2001, when Mothers to Mothers actually started its operations, we've reached 11,000 baby mother pairs from 2001 across the 10 countries where we have existence. And we reached 11.5 million women and children under 2 years. Okay, over 11.5 million. So that's basically the reach so far.
Okay, so now we go into our first poll question. The first poll question, I know that Mr. Elijah has done a lot of presentations, so he speaks quite fast and very seamlessly. So you snooze, you lose. If you feel that he's too fast, please just share in the chat box. He will slow down for your sake. Okay, first poll question. Since 2017, M2M has achieved virtual elimination of mother-to-child transmission of HIV among the enrolled clients for the 6th year in a row, with a transmission rate of 0.8% in 2020. Is this statement true or false? The poll has been launched. Let us vote. And this question reminds me of medical school when they give a lot of facts in the question or a lot of data. Is it true or false? Since 2017, M2M has achieved virtual elimination of mother-to-child transmission of HIV among the enrolled clients for the 6th year in a row, with a transmission rate of 0.8% in 2020. I can see we are voting so far. Okay, we are about to end the poll. We'll just give it 20 more seconds. I'll read it for the last time. Since 2017, M2M has achieved virtual elimination of mother-to-child transmission of HIV among the enrolled clients for the 6th year in a row, with a transmission rate of 0.8% in 2020. Is this true or false? Having had the majority of people polling, I think we've ended the poll. Not yet. So we'll continue with the presentation, and I'm sure the answer will be very clear as we go.
Thank you so much, Chair. I think Chair was trying to notify me that I'm a bit fast. I'll try to take it a bit slow, but very efficient so that we manage our time. So thanks for those that have been prophetic. I think I've seen people getting it correct even before the slide comes on. So thanks for being prophetic. So yeah, so Chair, thank you very much. So as an organization, what we do every year, we do internal data, performance data review, just to understand where are we going based on our vision, our mission. And remember, we are promising that our mission is to actually end pediatric AIDS. So we need to be very accurate with our data. We need to be reviewing. And so this slide simply shows that from 2014 to 2019, actually, there is 2020 missing there. We've managed to achieve 0.8% virtual elimination, but you've seen the way the flow of data is there from 2014 at 3.7, we came to 2.1 in 2015, 2016, 1.6, 2019, 1.9, and 0.8 in 2020. That's actually way beyond or below the UN benchmark of 5%. I know we have a lot of scientists in the meeting. They realize that the benchmark for UN for WHO is 5% for a breastfeeding population that we are Zambia. For non-breastfeeding population is 2%, and we've still hit even if we are a breastfeeding population. So correct those that got it correct. We congratulate you, but basically that's the start about virtual elimination. Next slide. Okay, so we are looking at the model enrollment as well as a graduation. So the model enrollments, we're looking at those clients that we've interacted with at the facility and we've actually enrolled them onto the model. Just to bring out a bit more information here, that so the standard model approach is that we need to have mentor mothers that are based at the facility to be focusing on facility interventions, as well as mentor mothers that we call community mentor mothers that are based in the community. But the model is able to evolve and respond to the happenings. So currently what we have in Zambia in the project sites that we have, we're actually using the same mentor method to do both community and facility. So that data you're seeing is those that we enrolled from 2018 when we started the model in Zambia to 2021. So you can see a very steady increase in enrollments from 4,655 when we started the model to 27,168 2020 accumulative data. That's basically the enrollments that we've been doing. I'd also like to disclaimer here, this was discussed in our prep. I think it would have been beautiful even for us. We love presenting our data in cohorts because our monitoring of data is actually in cohorts. We know in cohorts, we manage the data in cohorts. Would have loved to present this data in cohort. We had a bit of data challenge to pull out the cohort. So on the right of our screen, you see how many HIV exposed infants we graduated, or basically how many baby mother pair we graduated from 2018 to date. We're talking about 7,118 that have graduated. As I keep presenting, you'll be able to learn that actually those that graduated, we have a 98.7% negative final outcome, meaning they tested HIV negative after going through the model. That's also our organizational data, trying to showcase what contribution we've done to the triple 95s. The first 95, we had 99%. Those are women that were assessed and treated. Then we have a 98% of women with HIV that we saved and we adherent to treatment. And then we brought in a bit more early childhood interventions for you to just appreciate that for us to achieve certain results, we also need to take care of certain vertical activities. We need to take care of certain high impact activities that actually help the family approach to be enhanced. This slide is looking at some of the innovations that our digital platform as Mothers to Mothers have come up with. So if you remember very in early was at 2018 when we had gasing, correct me if I'm wrong, we had limitations here in Lusaka and Kwabewot to have a face-to-face interaction with our clients. And so as an organization, we realized that for us to ensure that we have adherence, for us to ensure that all the babies actually access the training as well as the mother, they have refuse and every other high impact activities that they need, we still need to continue interacting with them. We still need to remind them that they need to come back for this service because as an organization, we rely on a digital platform called ComCare. So this is a platform where we enroll all our clients and this platform is able to remind and tell us this client is due for a service, this client should come for a service, this client has received this service, this baby is due for a 6-month test, the mother is due for a refill and things like that. So this platform, we decided to make it a bit more responsive to our current scenario or the current normal. So we actually started what is called the e-service platform. This is a platform where we're able to interact with our clients, provide them with information, track what services they've reached, also provide services. For instance, we're able to have virtual support groups, virtual using this platform. We're also able to provide services. Currently, when COVID came up, also this platform made it easy for us as a model to respond, to sustain our gains, because then if we're not able to have a face-to-face interaction, we're able to reach our clients virtually. So that's what we're trying to showcase there, that we're able to provide these services even without a face-to-face interaction. So using technology, we're able as an organization to respond and sustain the gains of the model. So we have that platform that you'll be able to see in the slides that will follow how many in terms of numbers we managed to reach. We're able to use this same platform to actually refer for COVID testing. If we have at a facility, mentor mothers interact with a client who is not COVID tested, they're able to refer and we're able to capture those numbers. Thank you. So I was showcasing the organization as a whole from the 10 countries across the 10 plus countries that we are in. Now I'm going to drill down to what we've done in Zambia. So in Zambia, currently, Mothers to Mothers is working as a consortium partner under the USAID SAFE project. I'm sure most districts and regions are aware of the USAID SAFE. So we are a consortium partner there. We're the ones that are managed to manage the PMTCT in 34 sites out of all the GSI SAFE sites. So we're not in all the GSI SAFE sites. We're only in 34 sites. On the Copper Belt, we are in 22 as well as 23 and then 11 in Central Province. We are also privileged to be funded by UNICEF. So we have sites in Eastern Province under UNICEF as well as sites, a hub and spoke in Chipata level, and those from Chipata actually were pretty aware of this. And then we have our own funding as an organization. So we continued, UNICEF is funding us for Eastern Province as well as Central Province. We have a site in Central Province, and then Chipata level one, that's actually a funding that comes from within our organization for us to sustain the implementation that we're actually doing there, because the partner that was funding us pulled out. So we continue to have activities there. Thank you. We can continue.
All right. The second poll question. So far, so good. I think I am also learning quite a lot. I hope the network is learning too, because we've heard a lot about mentor mothers and now things are coming, more to light and the like. The second poll question is, the following are the epidemic control strategic objectives, except the following are the epidemic control strategic objectives, except A, to ensure that 95% of HIV positive individuals know their status. B, to initiate 95% of those who tested positive on ART. C, to ensure that 95% of those on ART are virally suppressed. D, integrate mandatory family planning services into 95% of HIV service delivery locations. Or E, to reach 90% of eligible HIV positive adults and children with NACs. We can launch the poll question. So the poll question has been launched. The following are epidemic control strategic objectives, except to ensure that 95% of HIV positive individuals know their status. B, to initiate 95% of those who tested positive on ART, to ensure that 95% of those on ART are virally suppressed. to integrate mandatory family planning services into 95% of HIV service delivery locations, or E, to reach 90% of eligible HIV positive adults and children with NACs. I know that the options are a mouthful, but I hope we've understood them. Let's continue to poll. I just want us to reach at least the 50% mark. We are 215 on the call. Only about 103 have polled. A couple more people to poll. We have 20 seconds. Okay, I think we'll end the poll at this point. So the majority think that D is the answer. Mr. Elijah, please.
Thank you so much, Chair. So I'll continue my presentation. So what I'll focus on now are strategic objectives and particular activities that were conducted or we are conducting as a model that actually make us achieve the gains that you're going to see after these strategic objectives as well as activities. And our wish as an organization is that these gains should not actually be left to slip in the cracks. We are actually, and we're happy that we've been interacting with Ministry of Health for us to ensure that these activities as well as the mentor mother model implementation in Zambia actually is standardized so that we're able to get to a point where the implementation is actually well defined and the gains are actually maximized. So Mother to Mother is very open to ensure that that is actually done in Zambia. So these strategic objectives are actually basically addressing the 395, the 999, the popular 995s, because we know that we cannot get epidemic control if we don't address those critical 995s. So the first 95, which is basically to do with testing, our mentor mothers, like I told you, the secret about the mentor mother model is this mentor mother, this lady who is HIV positive, who has a baby, who is sharing her story with this woman you meet in Ank who is just tested positive. She's confused. She doesn't know what to do. She doesn't know how to tell the partner that now been tested positive. They're all cultural and social economic issues that run through her mind. And then this mentor mother will be able to calm her down and explain her story, how she found herself in that state, how she's virally suppressed, how she managed to notify her family or partner, how she managed to undergo psychosocial counseling and things like that. So that story that this mentor mother tells is what makes these gains that I'm going to showcase in all the strategic objectives. Partner notification, I did already allude to that this mentor mother will help to take through this client. Can you be able, actually under the model, we don't call them clients, we call them buddies or friends, they call them each other friends. Take this actual client through this process and say, this is how we can do it. And she actually offers options based on the actually a client's response. Apart from the 12 days intensive training that I did indicate that mentor mothers undergo a 12 intensive class as well as facility-based training, they also undergo a standard psychosocial and DBS testing training. And that's how you find that in the sites where the mentor mothers are, they're able to collect these DBS samples and they're able to take the lab. Actually 96 or 94, some more than that, in sites where we have mentor mothers, the ones that are actually collecting these samples and taking them. That's how our EID in those facilities actually is doing and responding very well. The second 95 is talking about initiation. Our initiation is above 97% average. And this is because we ensure that linkage is done both for the infant and the mother, and this mentor mother using that experience I've already explained, encourages this mother actually to be linked into treatment. There are those that some of them mentor mothers meet mothers that actually tested and they started and they stopped in the process. When they meet the mentor mother, you find them actually restarting. It would have been great to bring up on board a mentor mother, just share this experience, but I'm sure next time as we are invited, Chair, will try to come with a mentor mother for them to actually share the personal experience and tell the story better than probably I'm portraying it. We conduct a lot of active follow-ups. I did indicate that we are using, we are benefiting from the intelligence of digital health, and so the M-Health platform that we use called ComCare is able to engage us into active follow-up. So when we know that this client is due for a service on a particular date, where we are able to engage. If this client is late, we're able to engage so that the client doesn't miss that critical service. And this is working for us. Yeah, thank you so much, Chair. Community and facility support group. So I did show you the e-services platform. We use both face-to-face support groups as well as the e-services platform. And so mentor mothers have created support groups in the community where they actually come from. And that's one thing that I needed also to emphasize, that when we're getting these mentor mothers, for instance, if we're having enrolling clients from a certain facility, we'll make sure those mentor mothers come from within that catchment of those facility for various reasons, and very obvious reasons that mentor mother should be aware of the community culture, the socioeconomic situation in there, so that as she actually is imparting her knowledge, people appreciate that she's basing on the experience that she can even quote and continue the interaction. So we do a lot of community support groups based on the need of the client. So we'll have support groups for adolescents, we'll have support groups for those that are looking at suppressing the viral load, we have support groups for women in ANC. So we have various support groups, and each support group is supported by particular mentor mothers so that she can understand her group's needs and respond to those needs. I should emphasize that when we are talking about all these activities, mentor mothers don't work alone, they work with a facility environment. So if you're talking about community, there's a lot of referral networking that happens in the community. There are other cadres, you agree with me, in the community that actually would make the work of mentor mother easy. At a facility as well, we have nurses, we have other clinical and other specialists that actually help. For instance, for viral suppression, mentor mothers have to conduct enhanced adherence counseling. They will work with this clinician to ensure that they visit this household or at a facility and provide this enhanced adherence counseling. To initiate 95% of those who tested positive on ART, I think I've already mentioned that. Thank you so much. So the other strategic objective, apart from 995, is what I mentioned, that we also need to respond to the high impact services that happen. So mentor mothers, apart from this interaction they have at the facility, to focus on testing, linkage, as well as psychosocial counseling for viral suppression and other activities. They also look at activities like referral for family planning. Okay, that's very important in the PMTCT prongs. I know we have specialists that understand better than me. That's very critical. So family planning is critical. So they ensure that as they interact for clients, they make referrals to family planning, they make referrals to VMMC, they make referrals for cervical cancer and other critical. Currently, I did mention that through our virtual platform, we're able now to refer for COVID-19 testing, because we realize that's very important. So we cannot operate in an environment where this mentor mother interacts with the client, but they're not verifying if somebody's not linked or has not been vaccinated. So we also, as a model, contributing a lot towards COVID-19, and we'll be happy next time to share how many in terms of numbers that we've actually done that. We also do a lot of nutrition assessment. Our mentor mothers do a lot of conduct a lot of nutrition assessment, both for the mother and well as the baby, to ensure that medication and everything else and nutrition, that actually interaction is very clear. We mostly apply the MUAC stripe for actually such kind, but they also go further when they do assessments. They do cooking demonstrations together with a facility, so that if it's cooking demonstration, there's a nutritionist there, and together they provide the service to that mother who needs it. Thank you. So this slide is actually looking at the testing in antenatal. Basically, we're trying to showcase what we've done so far in antenatal from first ANC. You can see from 2018 there, we had 11,000 when we were starting. We ended up 42,856. Very, very steady increase in testing. Testing is very critical if we're talking about epidemic control. So mentor mothers are aggressively addressing this issue through their skills, their experience, through their story, and actually that is happening. For the non-positives as well, you see the bars in between are looking at the non-positives that we've interacted with, from 1,186 to 4,567 from between 2018 and 2021. The last is talking about testing. From 9,858 to 34,702. It would have been great, and like I earlier said, these in the next presentation we'll make sure we break them down into cohorts so that people can appreciate from this cohort how many ended up actually at the final outcome with their infant. That would be good, and I promise that we'll do that next time. This is EID. It's very critical. I think this model is actually aimed at ensuring we contribute positively towards the Ministry of Health's struggles that they provide holistically these services to across the country. Our EID has actually tremendous numbers. You can see there's an increase there from 2,633 that is around 2018 to 17,133 using DNA. I did indicate that our mentor mothers undergo those trainings, 12 days intensive training done by Minister of Health, and they are certified. So that's how I'm able to record those numbers. Rapid antibody tests as well from 2025 to 13,118. So basically those are the numbers that the mentor mothers are contributing in the sites that I've indicated. 34 sites under USAID SAFE, as well as UNICEF, as well as our own funding. That's just a trend showing the linkage in antenatal from 51% when we started in 2018. We're just starting these sites. Mentor mother, we're still trying to get to enroll a lot more clients, but we managed to achieve 51%. Currently, we're above 100%, and I think I know we have a lot of specialists in data there. Realize that we're at above 100 because of those that find themselves where they're not supposed to be, because after 100, those that were supposed to be enrolled in the previous month, in the other month, actually they appear there. When I think we're able to advise the correct term there, because she's the guru there. So basically, that's what we're trying to showcase there. That's actually linkage for HIV exposed infants. Like I really indicate that actually our data is actually cohort monitored. So the mother and the baby pair are supposed to move together and showcase. So there is basically the linkage for the infants. It was easy for us to link infants when we were starting, but we've maintained and sustained that. We had a bit of an itch in 2020, and then we managed to sustain, and we are making sure that 100% of all the infants that we know are actually linked to care. Viral suppression, the triple 95 is key. By 2018, we were around 81, but you can see a very steady and a progressive increase to 99.2% in 2021 out of the mothers that we enrolled. So apart from the triple 95, like I indicated, we also do other high impact activities. So there we just wanted to showcase what activities we've done around adolescent health. We all understand that that's a priority population and we can't leave them behind. So we find our mentor mothers who are adolescents themselves, who create support groups for adolescents. And when they interact with them at the facility or in the community, they will refer them on various key activities. For instance, we refer our adolescents to dream centers for other management. We also, some depending on the situation, we refer them to various partners on the ground. So there's a lot of networking. Mentor mothers don't work alone. They don't work alone. They work with other partners on the ground. So that's basically showcasing adolescent health activities. So we managed to have adolescents tested 27,961 so far. Adolescents tested. And then those that tested positive had 1,166. And if you look at the initiation there, that's 100% initiation of adolescents. If you look at the third bar there. Linkage for family planning, 26,813. Linked to dreams, like I did indicate, we have 1,962. And then active support groups for adolescents. Basically, adolescents, just we have 23 that are active in the sites that we are implementing. I did allude to e-services, that this is a platform that has helped us sustain the gains. I think Minister of Health and other partners who agree with me that during the COVID and during gassing, we lost a lot of clients. There was a lot of loss to follow. There was a lot of people that actually were not adherent. And so through this platform, we're able to sustain our gains because we're able to reach them still, we're able to call them still, we're able to provide them services still. So we actually enrolled 10,961 on the VMM services, and then clients code for structured and motivational education because our courses are structured. So the first call will be basically to introduce the platform, and the next call will come up based on the client service that is due and things like that. And then we also have calls that are actually just focusing on active follow-up to ensure that this client comes to the facility for a particular service. So we had 23,810 clients that actually were called. And then follow-up calls for clients missing appointments were 13,011. So those are clients that had missed an appointment at a particular date, and then we needed them to come back. And for us as a model, when we say a miss, we're not talking about a month, we're talking about a day of missing, because immediately a client misses a day, ComCare, which is our digital platform, is able to tell us and it's able to flag that this client has missed. Can you make sure this client gets back? So when I'm talking about missing, we're not talking about a month, we're just talking about a day of missing of a service. Thank you, Chair.
Okay, thank you, Mr. Elijah. I know that he's been quite fast, but he's also been quite clear, and we will seek more clarity even after the presentation. Thank you. Poll question number 3. for question number 3. Which of the following are best practices of the mentor-mother model? Which of the following are best practices of the mentor-mother model? A, remote services. B, peer approach. C, facility to community platform. D, integrated service referrals. E, digital tools. Or F, or the above. We can launch the poll question. Which of the following are best practices of the mentor-mother model? A, remote services. B, peer approach. C, facility to community platform. D, integrated service referrals. E, digital tools. And F, all of the above. Let's get polling. We just have about a minute. You can see the answers are coming in real quick. Very interesting. Which of the following are best practices of the mentor-mother model? This is a single choice answer. Remote services, peer approach, facility to community platform, integrated service referrals, digital tools, or all the above. I can see Chitokoloki is discussing which one should be the answer. And Chitokoloki, we're waiting for you to vote. We'll end the poll at this point. Thank you for polling. So the overwhelming majority seem to think that F is the answer. Let's find out.
Thank you so much, Chair. And yeah, thanks. It's good to see that people are able to engage into discussions. And I hope those were not leakages sharing the answers. But yeah, we appreciate the discussions that are going on. So what are the best practices? What is it that we want to see, or what is it that has made us gain what we've presented as a model? And what is it that we want to see replicated in other sites where we want to actually grow as a model? The first one is remote sensing. So we are saying, can we roll out the virtual mentor-mother platform? Because, you know, I think gassing COVID-19 has actually proven to us medical fraternity that actually things can change. There could be a time when you cannot actually provide a service without a face-to-face interaction with a client. And this has taught us, and our digital platform has actually made life easy for the mentor-mother and for us as an organization to continue providing a service even without a face-to-face. So we are saying that's our best practice, and we want to see if we can replicate this and grow further. The peer approach, I think this cannot be overemphasized. I think I've said the best secret of this model is that peer approach that we are using from this mentor-mother's personal experience to the client that they meet in RMNCH, in PN, or anywhere within the service platform. That's very critical, and for us we want to emphasize, like I earlier indicated, that let's utilize this peer approach. Let's standardize. When we're mentioning a model called the mentor-mother model, what are we talking about? Are we talking about this mentor-mother based on what we prescribed here? We need to have this prescription so we can standardize and achieve these gains that I've actually showcased. Facility to community platform, I've indicated already that we want to have a session where facility and community are interacting. We cannot have any activity that actually is effective on the facility. Most public societies agree with me with that community activity, because that's where most activities are happening. So our platform, our model is able to have a mentor-mother in the community and the mentor-mother at the facility interact. But like I said, currently in Zambia, we've tried to use a hybrid approach, if I may use that word, where a single mentor-mother is able to do both a community and facility activities. But a standard mentor-mother model is a model where we have a community mentor-mother who is just focusing on community activities, community interactions, but there's a lot of active interaction and referral between the facility mentor-mother and other structures within the community. integrated service approach. You've seen in our presentation that we focus much on the 3.95s, but we've also tried to showcase what we've done in nutrition assessment. We've tried to showcase what we've done in referrals for family planning. We've not shown you the numbers, but I've indicated or mentioned that we do a lot of COVID-19 referrals as well. So we want to continue that integration approach because we realize that for us to get to epidemic control, you cannot leave a certain intervention alone without actually patching it through. We are already actively involved as mothers to mothers as part of USAID Safe in SAGE strategy that the Ministry of Health actually has initiated, and these are really helping. And we are using our experience, or using our best practice as we go through these SAGE activities to showcase and see if we can replicate this. So we are actually participating a lot in those because we realize these actually are helping us to sustain as well as improve the gains that we have as a country. Because at the end of the day, we're focusing on the country. The next slide. Okay, so this is a summary of achievements, just in case after the presentation, some achievements have dropped into the cracks, and I hope I wasn't too fast, people were able to grasp what I was talking about. The first is that from inception 2018 to date, the mentor mother model implemented by Mothers to Mothers has enrolled mother baby pair number of 27,168 into the model. And we've consistently recorded an ART initiation of above 96% among the pregnant and breastfeeding women, which is actually great, and that's what we need as a country. And that's why we're talking about replicating this model into other sites where we are not. Increase the number of proportion of the not HIV positive and natal clans at RMNCH from 2018 where we had 51% or so, and now we are talking about above 100 achievement, which is a great achievement, and we cannot let these achievements actually slip into the cracks. Proportion of HIV exposed infants who received PCR test results increased from 61% in 2018 to 108 in 2019 to 123 in 2021. Those stats are speaking for themselves. This model has shown the numbers, has shown what it's able to achieve, and we've actually shared how and what's supposed to be done. MTCT rate of 0.4%. This is Zambia-based data after we did our internal data review and evaluation. By 2020, we had 0.4% MTCT rate as a Zambia, which is way below the 5% like I indicated. What are our aspirations as an organization? We are saying, can we take the current model, which is the model that I've presented, to scale? Let's scale up, and we are privileged and happy that Ministry of Health has already started doing this. We are interacting with Ministry of Health, and we are trying to see how can we scale up so that these gains actually are replicated, they are taken to other places where we are not. We take it to Zambia, take it to Chama, take it everywhere we are not, so we can see that as we are running the last mile, we smile together as we look at these numbers. Strengthen the integrated approach. I already did mention that, and I think I emphasize that in our best practice. We cannot do this intervention alone. We need other activities that are there. So as the model, we're also trying to expand and ensure that we take advantage of other activities that are existing. Increase focus on adolescents. That's a priority population. Apart from adolescent girls, which is most common, we're also trying to say, we'll not just focus on girls, let's also look at adolescent boys, and let's take it holistic. So we are trying to see if we can pump in a lot of effort in that vulnerable, that priority population, and then get the gains and spread those gains. Prioritize on community-based activities. We need to actually capitalize on the family-centric approach. We are a family-centered model. We would meet this mother in ANC or in postnatal nurture within the facility setup, but then our mentor mothers will take this relationship to the family. They will help to ensure that there's no intimate partner violence, because this mentor mother will explain how she managed to handle that with her husband or with any family members. She will ensure that this adolescent who is within that household actually has the services that are required, but she also ensure that if there is a need for testing is also conducted, in the index is also conducted within that household. So this family-centric approach is actually helped us to gain a lot of results, and we want to continue and expand on that. Enhance coordination and partnerships. We're not going to be here if it wasn't for coordination. We thank Ministry of Health and other partners. We don't work alone as mothers to mothers, and so want to enhance and continue expanding this coordination, because we know that as a country, for us to hit epidemic control, we need to work as a team. Because they said together, I think you know better. So I think that's basically what we are trying to focus on. Thank you so much. I hope I wasn't too fast. Thank you so much.
All right. Thank you very much, Mr. Mvula. That was a really good, eye-opening discussion. I had a discussion with our very resourceful health system strengthening nurse from Charleston Sub-District, Mainza Mianda. she talked about this model, the mentor mother model, with so much passion, and you could see that she knows her statistics, she knows what she's talking about. Some of the takeaway points that I gathered for myself is that, a mentor mother should be HIV positive, obviously. This is someone who has to have lived this experience, okay? And they should be a mother, okay? From some of the discussions that we've had. So at this point, I know that we may have some questions, and so we will open the floor for discussion. I know Mr. Mvula for him, that's his normal way of speaking. He was a bit fast for most of us, and we'd like to clarify a point or two. Please use the chat box, or indeed you can, raise your hand and we'll be able to pick on you. Before we get into the discussion though, we will at this point re-poll so that maybe we just discuss the poll questions. We see what, the answers were, and then we get some clarity where we were not very clear. For those of you that joined late, kindly take advantage of the registration link in the chat box. Use the chat to be able to register your presence. The first poll question has been launched. The question was, since 2017, M2M has achieved virtual elimination of mother-to-child transmission of HIV among the enrolled clients for the 6th year in a row, with a transmission rate of 0.8% in 2020. May we please take 30 seconds to poll? Out of 216, only about 30 have polled. Chinsali General Hospital, go ahead and poll. Chitokoloki Mission, go ahead and poll. Since 2017, M2M has achieved virtual elimination of mother-to-child transmission of HIV among the enrolled clients for the 6th year in a row, with a transmission rate of 0.8% in 2020. Remember, I was saying, when you see a question with a lot of facts, what should that remind you of? Is this a true or false statement? 10 seconds to poll. Okay, we'll end the poll here and then we'll discuss the results. So the overwhelming majority think that this statement is true, while 7% think it's false. Mr. Mvula, please take us through this discussion.
I understand the 7%. I think it's teaching me that I need to be a bit slow, but I also appreciate that 93% got it. So I think I just need to see the balance there. So I think that's a true statement. And the slides that I went to actually showcase the stats to just amplify and show that actually, yes, mothers to mothers from the sites we're implementing. I did indicate that we're in 34 sites out of the 304 USAID safe sites. If I've not missed my stats. So in those sites where we're in, that's where those stats actually apply.
All right, thank you. We go to the second poll question. Poll question number 2. Poll question number 2. The following are the epidemic control strategic objectives, except the following are the epidemic control strategic objectives, except A, to ensure that 95% of HIV positive individuals know their status. B, to initiate 95% of those who tested positive on ART. C, to ensure that 95% of those on ART are virally suppressed. D, to integrate mandatory family planning services into 95% of HIV service delivery locations, or E, to reach 90% of eligible HIV positive adults and children with NACs. Let's keep polling. We have about 20 seconds. So we'll end the poll here and we'll discuss the question. Mr. Elijah. So the 64% think that D is the answer, which is to integrate mandatory family planning services into 95% of HIV service delivery locations. Most people are saying that is not an epidemic control strategic objective. So please give us.
Okay, so I think this poll has shown that there was a bit on the first, because I've seen that I think those that are saying D and those that are saying E, there's 31 and there's 64. We still have a few more, but yeah. So amongst our strategic objective, I think we're not talking about mandatory family planning. We just mentioned issues to do referrals for family planning services. So the answer is D.
Okay.
Definitely, this teaches me that I need to be a bit slow and more clarity should be provided. I'm happy I'm sitting with lecturers near. They will teach me how to do that better. Thank you.
All right. Thank you so much. We can pour the last question. Okay, the last question is, which of the following are best practices of the mentor-mother model? Which of the following are best practices for the mentor-mother model? Is it remote services? Is it peer approach? Is it facility to community platform? Is it integrated service referrals? Is it digital tools, or is it all the above? This one is pretty easy. People are polling very quickly. We have about 10 seconds. Okay, we'll end the poll here and then we'll just ask for advice from Mr. Elijah. So the majority think that all the above is the answer, with just a few people thinking that it's one or the other.
Yeah. Sure. Well, thank you so much. So for the few that didn't get me clearly, so I think I did indicate amongst our best practices that one, we're talking about remote sensing. I talked about e-services, that we need to have e-services for us to actually interact with our clients without actually a face-to-face interaction, and all those actually, so it was all of the above, because all those actually the best practices that we want to see if we can replicate in other sites.
Okay, thank you so much, Mr. Elijah. For this presentation, it's really opened a lot of avenues for information. Now, people that were wondering what this model is know that there's actually a model, and they know that M2M is now it's an organization, and we're rolling out the mentor-mother model. So we have some hands. We'll go into the discussion. We'll discuss around the topic. We have, let me just confirm once again, our panel of experts. Dr. Priscilla Banda, are you with us? I know Gwen Yondela and Dr. Chimika Piri are still on the call. So even as we get into the discussion, okay, I've been told that Dr. Priscilla Banda is also on the call. So we'll go into the discussion. I can see Annette from Avention. You can unmute yourself and give a comment or a question. Thank you.
Good afternoon. Thank you very much. Good afternoon, network. Thank you very much for that presentation. It was very enlightening, and well done to the work that Mothers to Mothers is doing. I might have missed it when he was giving the overview. I just wanted to ask if the organization is extending index testing, because I'm sure we have mothers who are living in home setups who are married, but we should have some key populations like female sex workers that we deal with also. So do we extend index testing for the social networks? Thank you.
Thank you, Annette, for that question. Do we have any more questions? Mr. Mvula, you can probably take that one. Are you extending index testing? Is the question from Annette.
Thanks, Annette. I hope I got her question clearly. So we do conduct index testing, like I indicated that our approach is family-centric, but I think our extension goes to that household of that a particular woman that we actually have enrolled. So we do index testing for our family, but you know, index testing, when you come from the family to the network will keep growing. So yes, the question is yes, we do conduct index testing because that's the one way we'll actually be family-centric. We need to actually follow up the networks of a sexual partner as well as a woman that will be enrolled.
Okay, thank you. Annette, is that clear?
Yes, that is clear. Thank you very much.
Okay, thank you so much. We have a comment from Michael from Mehari in the chat box. As Mehari Medical College under the HBC in Lusaka, we have the Mentor Mother Model services at Chilenje, Chawama, Matero, and Kanyama, working in collaboration with PHO, Lusaka PHO. It's a very good model to use in MCH, and thanks to M2M for the added information. Sister Mwinga is asking in the chat box, I heard the presenter talking about linkage of adolescents to mentor mom. How is this done? Please clarify. I heard the presenter talking about linkage of adolescents to mentor moms. How is this done? Please clarify.
Thank you, Sister Mwinga, right?
Yes.
Yeah, so I think what I meant there is that, you know, when you're providing a service at a facility or in the community, there are those mentor mothers who interact with through adolescents. And so you know that there is a lot of sensitivity amongst the adolescent population. And so these mentor mothers will create a safe space. So this linkage is actually for other further management and other opportunities. For instance, I did allude to the dream centers. So after managing this adolescent with a mentor mother, the mentor mother would actually link them to a dream center or a service that actually that adolescent is interested in. If it's family planning, they'll conduct a linkage to family planning. So I think that's a linkage. I hope Network and Chair got that question clear. So we do refer, yes, adolescents, and we have mentor mothers who are adolescents themselves. So they'll still share that experience that they had as adolescents based on how they found themselves positive and how they managed their situation with these adolescents in that safe space that they'll create.
Okay, thank you. Does that answer suffice, Sister Mwinga? You can just quickly tell us in the chat.
For now, it does. Thank you very much.
For now, okay.
I like that.
Thank you. Lina Mwango is asking, kindly explain the incentive package for the mother mentors, you know, and I mean, I've also been wondering, are they on a salary? These mother mentors or mentor mothers, are they on a salary? What is the, you know, incentive package?
Thank you so much. What's your name, Lina? So
yes.
Thank you so much, Lina. And I think our panel of experts, I think we have Priscilla and Mishek, please feel free to chip in. Yeah, so I think I would take you back a bit. If you saw my first slide, I was talking about the vision of mothers to mothers. So I think the vision of mothers to mothers is built on what plans we had for this HIV positive lady that we are calling a mentor mother. So apart from thinking about this mentor mother, a lady called mentor mother, helping us to link, to test, to achieve all the results that I've shown, we also saying, can we also give her hope? Can we also make sure she's empowered? And so, yes, these are not volunteers. These are these are payroll staff. Whatever conditions I have, It's actually what a mentor mother has. So yes, they are payroll staff and they actually get their salary on a monthly basis, just like another mother's employee.
I don't know if Mwila, you were trying to speak, but your network is pretty bad. Hello, Mwila, we can't get you. Mwila, maybe you can type your comment in the chat box. So Lina, the gentleman here says that, yes, these are actually, their payroll staff. He's saying the conditions that he has, they also have. If he has a holiday package, they have a holiday package. Health insurance, they have health insurance as well. So these are salaried workers. I hope that answer suffices.
Okay, not really. So maybe we'd reach out further to really understand their package, which I'm sure includes a certain fringe packet and other incentives, because he has just said what he has is what they have. So really, I wanted to hear what numbers are involved, even as we are trying to scale up this model. Is it scalable? What will happen to the mother mentors that have been recruited under M2M? Is the Ministry of Health going to take them on since they are salaried workers? So wanted to hear the transition plan, the sustainability plan, and also the numbers that are involved in implementing this model. Thank you.
Okay, so I don't know if you were able to speak to that, or you would like to take this discussion.
Yeah, so yeah, I think issues of rights, issues of HR, I think if we have HR, you understand that I can't talk about the docs figures here. I think that's a personal thing, but I think you are free to come to offices and get to engage us, and then we can look at sustainability. I think that's the focus also as an organization. So feel free to reach out through email, then we can set up a meeting, and then certain issues that are strategic and cannot discuss in a group can be shared with you.
Okay, thank you for that response. Mumbi from PHO is asking, is there any consideration for increasing uptake of COVID-19 vaccination among this population?
So thank you, Mumbi. Yes, I think thanks for that. I think I should have mentioned that. So our mentor mothers, just like viral suppression for us, we make it mandatory that they actually, if they're talking about having a peer interaction, they should be able to showcase this buddy or client or friend that actually look at my viral load is suppressed because I do A, B, C, D. COVID-19 as well, all our mentor mothers are 100% vaccinated as well as certified. And that's why I did indicate that apart from referring for family planning, VMMC and other high impact services, we also refer for COVID-19 vaccinations as well as testing. So that we do, yes. And we're hoping that next time we can showcase the numbers that we are referring.
All right, thank you. I hope, Mumbi, you're satisfied with the response.
Yes, I am. I think it would be good, like the presenter has said, if he could have shown the uptake, it would have been very good to see, because the model is working according to this presentation. So meaning that it would be easy for us to get numbers for COVID-19 using this model.
Yeah, and I absolutely agree with you. Is someone trying to speak? Okay. Mwila, I don't know if you are trying to speak or your mic, you just, keep unmuting. Okay, so I know that we have panel of experts with us. So panel of experts, please feel free to chip in, even as these questions are coming through. I know that there's a small section where you are able to give some expert recommendations, just to have a collaborative discussion. But feel free to chip in to answer some of the concerns even in the chat box. Magomo from Siders is asking, what is the standard attachment ratio of M2M to recipient of care paired? What is the standard attachment ratio of M2M to recipient of care paired?
That's what's the name?
That's Magomo.
Magomo. Thank you so much, Magomo. So I think the standard ratio for the mental mother is 1:10 if we follow the prescribed standard. But then we use the PMC historical data for us to extrapolate how many mental mothers we want per site. But like a healthy workforce, if asked, okay, what's your ratio to get to a facility with a client, you find that you tell he's able to see what he should have seen across his professional lifespan. So mental mothers are also having that, because remember also we also trying to see how best can we have a service done with this number of mental mothers. So yeah, so the standard is 1:10, but if you get the facility, you know, our facilities are high volume, and you know, always there's that compromise that we get into. Yeah, but for us to extrapolate, if we extrapolate to people to, you know, here we need 100 mental mothers, but then if we look at the situation, how many mental mothers will we have employed for us to have a service, a package implemented?
Okay, thank you. Magomo, is that sufficient?
Sure, great. Thank you for the response.
Sure, thank you so much. So Chitokologi mission is saying that Chitokologi mentor mothers are not trained in NAT. Is there a plan to train mentor mothers in NAT testing?
Yeah, so yeah, I think that question I'm sure will be handled by the panel of experts, I think from MoH, because that's not a mother-to-mother site. So I think that definitely has been taken note of.
Okay, I think there Gwen Yondela is probably taken note of that question, even as we invite the experts. So good presentation. Kindly share how many recipients of a care are linked to a mentor mother. I think this question was answered, and explain how they are zoned in the community for easy follow. Probably just speak to maybe how they are zoned in the community for easy follow.
Yeah, so I think the same ratio thing will still come up, but the way they are zoned is, for instance, like I indicated, a standard mentor mother model will have a number of mentor mothers based on how we extrapolate based on the PMCT historical data. So if we establish how many we have, then from that facility catchment, we'll not zone them. So like I indicated, when you're employing these mentor mothers, for instance, if a site or an outreach or post is called Elijah, we need to pick a mentor mother from Elijah site. So at Elijah site, actually as a mentor mother who understands the dynamics of that site and how many clients are actually been enrolled on the model. So it's easy for the mentor mother to follow up, apart from using the intelligence of ComCare, which is able to tell the mentor mother, the client who is due, where the client is, because the location is there and everything else. So apart from that, it's actually the issue of having a mentor mother who comes from that area for easy follow-up. So not pick a mentor mother from Lusaka, we train, then we send that mentor mother to is it Stogoloki? Mm-hmm. Yeah, we'll pick somebody from there so that person understands the social of that area, and then to be easy for that person to interact.
Okay, thank you so much. So the next one is they're just asking about, you know, formal and other qualifications. What qualifications should the mentor mother have? As we already spoke, this must be a mother. This must be an HIV positive person who's been through the experience that they are trying, you know, to showcase to the other people, to mentor others on. I don't know if there are any additional qualifications you'd like to add?
Apart from that, our mentor mothers, when we are recruiting them, should actually a minimum of a grade 12. We have mentor mothers that are university graduates that we have as mentor mothers, but the minimum for us, for easy understanding, interpretation of data, and actually just make sure that they transmit the right information, we actually take a grade 12 as a minimum.
Okay, thank you. So I see, Chitokoloki, you still have a lot of questions. These ones will be dealt with by Gwendolyn from MoH. She'll be able to, yeah, she'll be able to come through. We also have Dr. Chimika, who will speak to the same about, you know, procedure for putting these mentor mothers on payroll and the like. So from your presentation, I also heard you talk about graduating some clients from your care, zeroing it to the Zambian setup. Do you perhaps have numbers of how many have been graduated as a way of demonstrating impact? Thank you. I think this one again, Sister Mwinga is just asking about some of the numbers that you had already displayed. I remember, so I think that's what she's just asking about.
Thank you, Network, and thank you, Chair. So I did showcase, I think that was slide number 8, where I was saying we've graduated 7,118, and graduation, just to be simplistic, means that this baby mother pair has gone to the 24 months final outcome test, which is a last test at 2 years. So yes, and that's why I said actually also emphasize that next time I think we will try to present our data and cohorts so that we say, look at this cohort that we enrolled in 2018. By 2020, out of 199 have actually graduated with a final outcome which is above, which is negative. Like I indicated, we have a final outcome, negative final outcome of above 97%. So yes, we have data of graduated. So currently we're talking about 7,118 that have graduated with above 97.8% final outcome HIV negative. So stats are there, yes.
Okay.
Good afternoon, Chair.
Good afternoon, Dr. Priscilla Banda.
I'm not a doctor.
It says Dr. Priscilla Banda. You're an expert.
Thank you for the honor.
Please,
good
go
afternoon,
ahead.
everyone. The presentation that we have made is extremely summarized, and I would like to request that those that require in-depth information can reach out to the Mothers to Mothers team and get more in-depth information. In Lusaka, we are at Chipata Level 1 Hospital. We can even conduct a site visit for people to understand what our model entails and how it works on a practical level. So after this presentation, maybe Secretariat can link us to the teams that need further interaction, and will be more than willing to share, because this was highly summarized. Thank you, Chair.
Thank you so much, Ms. Priscilla, for that input. So I also know that maybe perhaps people are wondering, could you just clarify that M2M, the mentor mothers under M2M are not necessarily the ones that are, because there are some sites apart from Chipata Level 1 that have mentor mothers. Just to clarify, is it so that these mentor mothers are not really the same? However, is it that the training is different, or do you train all of them at once, or the ones under LPHO, for example, are they trained separately from the M2M mentor mothers?
I'm sure LPHO is on the call. They can clarify. Our mentor mothers are not trained through the LPHO program. We've got specific funding from specific donors that has supported the training of the mentor mothers in the sites that we made in the presentation. Nonetheless, there have been attempts to implement the mentor mother model outside of Mothers to Mothers. And we are hoping that through the dialogue and discussions with the ministry, that will harmonize and standardize the mentor mother model, because there's certain criteria that actually contributes to the success and the elimination numbers that we are showing. There are certain things that we do through this model that makes it that success. And as an organization, we feel that the Ministry of Health coming in and providing that leadership to harmonize the mentor mother model will actually increase its bandwidth, its footprint, but also its quality service provision. We need to maintain a certain criteria and quality for the success of our model. So thank you so much.
Thank you very much. I think that was very clear. I saw Nathan. Nathan's hand was up. Nathan, have you changed your mind? I know you're very passionate about pediatrics. So please make your comment or you can ask your question.
Sure, thank you very much, Dr. Mona, and good afternoon, network. So yes, I'm just trying to also come on board based on that reaction in terms of the implementation of the model. So as I already mentioned, we've been implementing the mentor mother model, even as PHO for the PMTCT program. So at the point of inception, we did indeed seek guidance. Actually, the model is from the mentor mother team. Actually, that's can I say the pioneers of it. And so even at the time when we were trying to incept a model, we did further consultations as a PMTCT unit here at the province. So much of the guidance basically has been from them. And then from there, we did scale to our partner, that is Mehari, as they have said that actually. So we're implementing the mentor mother model in Lusaka together with Mehari. And so Mehari, when we are bringing them on board, we really also wanted to focus more on the community approach of the mentor mother model. So that's how actually the implementation has been. Well, as PHO, we implemented the model at static sites, that is in the hospitals and facilities. Mehari has been on board to strengthen, taking the community model. I must say, actually, yes, we may not be implementing the model as 100% as the way the mother to mother are doing it. Nevertheless, we've really tried to seek guidance and inquire for them as we've been trying to implement. Suffice to say that, as already commented from them by the previous speaker, we really look forward to further engagements, especially as MOH comes on board to, I think, synergize. We would really love to implement a perfect model of it. So we really welcome and look forward to further guidance, further technical support, and so forth, so that we indeed get the full benefits. Otherwise, at this point of implementing the mentor mother model for more than 1 year, 6 months now, we as PHO, we've really seen the difference actually in terms of coverages for the PMTCT throughout all the cohorts in the facilities that are implementing the model and those facilities that do not have the mentor mothers. So with very good collaboration, a very good technical support from the mother to mothers, we could really synergize and have one package as a whole. Thank you.
Thank you so much, Nathan, for that comment and for the encouragement that you are giving. At this point, I'd like to invite Gwen from MoH, just maybe in about 3 minutes or so, just to share some, expert recommendations. Thereafter, we'll have Dr. Chimika Piri, who also give us some expert recommendations. Gwen, are you able to unmute and just give us some recommendations?
I think I'll let Dr. Chimika take up that.
Okay, no problem. Thank you so much. Dr. Chimika Piri.
Yeah, so thank you very much, Chair, and I'd like to thank you, M2M, for the wonderful presentation, in particular Elijah Mvula, and also I'm glad that Priscilla Banda is on board. And I could see the positive contributions from the network and also the questions that are coming through just show that people are interested in the topic. So as Ministry of Health, you know that under the PMTCT program, our goal is to eliminate, now we have added syphilis, so we want to eliminate HIV and syphilis to a level where the incidence is low in the population so that it's no longer a public health problem. And to achieve this, we have what we call the process indicators that we've been tracking. These are in line with the WHO guidance. So looking at the 2021 performance, national performance, we identified, of course, using UNA statute analysis, we identified some of the challenges that the program is currently facing. And when we looked at the some of the best practices, some of the strategies that we could bring on board just to help bridge this gap, the mentor mother model is one of them that we identified based on the successes that have been shared by M2M. I must be quick to appreciate that as a ministry, we are aware that quite a number of facilities and provinces are implementing the mentor mother model. The approach may be different from one region to the other. And because of these, and I could see some of the questions that are coming through, as a Ministry of Health, we've taken this up and see how we can harmonize and sort of standardize with a lot of consideration in mind. So our approach is, we are currently in collaboration with M2M to see how the ministry can actually adapt some of the best practices and help scale up this activity across the nation, the country. So one of the key issues that we as a ministry want to take into consideration is sustainability of these activities, and already would want also to learn from some of the provinces, partners that have been implementing the M2M, so that looking at the gains and the successes across, we can then now, with of course consulting with the various stakeholders, we can now consolidate and produce a standard guideline that will be domesticated for Zambia. So among the areas that we want to see, if we could also expand some of the scope of the activities for these mentor mothers. I know we are struggling in terms of IRT coverage, we're at 8%, and also have noted that we're still having incident infections. So our approach is to see how some of these, the 4 prongs, can be supported from primary prevention, and we are glad to see that some of the approaches that M2M are using can actually fit into our agenda. So they have activities around prevention of HIV, targeting the adolescents and young girls, and also the boys. And also we learned that they are into family planning. And also we know that some of these mothers that tested negative during pregnancy, they circumvent, and we are seeing quite a number of exposed infants getting infected. And also the cohort want to strengthen that area. So we also want to see how we can bring on board case finding, including one of the activities that the Ministry of Health is recommending, the index testing, including the neo-child status. So we are looking at the possibility of evaluating the scope of activities that these mentor mothers can actually support, looking at what is obtaining on the ground in Zambia. So this to us as a program is a priority activity, and so far we are still engaging M2M. We just had recently had a stakeholders meeting with CDC, USAID, UNICEF, and where I must mention this was very fruitful. So we are hoping that soon our concept note should be finalized, and also at an appropriate time we should be able to guide the nation in terms of the way forward. But I think based on the presentation, we appreciate, and the data, we appreciate that. And also the remarks coming from the provinces already, we see that this is one of the best practices or model strategies that we can bring on board and expect to improve some of the areas that we're not doing well as a PMTCT program. I think that to be my comment for now. Thank you.
Thank you so much, Dr. Chimika. Indeed, I think you've actually, summarized the presentation. So again, I'd like to extend thanks. So our watch says it's 4 o'clock, and I think we've done well on time. We've come to the end of this session. This session was on mentor mothers supporting the full cascade of PMTCT services in Zambia. And we've seen from the data presented, albeit it being very summarized, but we've seen that this model works. And we are glad to bring it on board so that, and then we'll see how we can improve on it to be able to extend it to other conditions as well, apart from PMTCT. So just a reminder that one last time, the link has been shared in the chat box for you to be able to register your attendance for this session. Mr. Elijah Mvula from M2M was the presenter, and I was your host, Malilwe Muhuma. But before we go, we'll ask Etambuyu to just give us the next topic that we'll be looking at next week. We expect that a lot of you will come back next week and join us again for another great presentation. So kindly hold for Etambuyu.
So good afternoon, network. Thank you very much for that very introductory echo. I, for one, really enjoyed the echo session. So next week, please, you do join again. We'll be looking at gender-based violence. It will be presented by Dr. Malilwe Muhuma, our able facilitator today. And also it will be facilitated by Dr. Matibula. From me, I think it's bye and thank you.
So thank you very much once again, Network, for having joined us for this session. Remember, these sessions are recorded and uploaded on the YouTube channel, the MothersSupporting Echo Zambia page. You can find these videos on YouTube. So I was your host, Malilwe Muhuma. We'll catch up next week. Thank you and bye.
Thank you, bye.
Thank you, bye.